Okay. Hello everyone. Welcome to my name's Amy Barrie, and I'm the lab director for Care Chester and Care Liverpool, and I am joined by...
I'm Sephton. I'm the medical director here at Care Chester. I'm also the deputy medical director at Care Liverpool. And this evening we're going to spend about half an hour answering lots of questions that have been submitted before this evening, but also trying to get through some of our live questions as well. We'll promise we'll try and do as many as we can in that time. What we aim to cover is to look at what makes a good embryo, how we make embryos, look at a little bit about embryo development, about their grading, what time-lapse is, what genetic testing can be performed on embryos, a little bit about embryo transfer, and we'll try and touch implantation as well. We have received so many questions asking our opinion on very specific embryo gradings and quality and what this means in terms of success. And because there's so many factors that can contribute to an individual's IVF success, it's not all just about the absolute grade of the embryo. But we'll try and speak as broadly as we can so that we cover as many of your queries that you've raised. But often we don't have time to answer each individual question. But please definitely call your clinic and your embryology team, and they'd be happy to give you that information about your individual embryos if you don't feel that we've been able to answer it broadly this evening. Thanks for all of your lovely messages that we received in advance of this event, and we're getting quite used to doing these now, and it's lovely for you to cheer us on the way you do, so thanks for that. So we'll start with the first question, and Amy, you're probably best to answer this.
So there's lots of different things that we look at, but really when we're looking at embryos, we mainly look at them on day 3 or day 5, and the main observations that we make, the most important observations that we make, are probably on day 5, and we're looking for 3 things really. So the first thing is how big the embryo has got. So when it becomes a day 5 embryo, it starts to get bigger in size. That's not necessarily a indicator of quality, but it's something that we do look for. The second thing is for something called the inner cell mass, and that's the bit that will eventually go on and create the baby. And we grade that inner cell mass according to a grading scheme that we use in the lab, and we're looking for a big group of cells all grouped together in the embryo that we can see very clearly. That would indicate a good inner cell mass. And then the third and final thing we look for is something called the trophectoderm, and that's the cells that are around the inside of the embryo, lots and lots of little cells, and they're the bits that become the placenta and all the accessory organs around the baby. And we're looking for uniformed cells, lots of them, and that indicates a good quality embryo on day 5. I've just had notification that we aren't live on Facebook yet, so I'm going to try and sort that out, but perhaps you could carry on.
Okay, so one of the next questions is, do you always fertilize all eggs? So this really is decided upon. You may be having ICSI as part of your treatment, or you may be having standard IVF. For standard IVF, the eggs and the sperm are left to fertilise naturally in the lab overnight. But for ICSI, then the eggs have to be stripped and checked to see if they're at the correct part of the development where they can be injected. And they have to be at a certain phase of division to be injected safely. And if they are, then they would be injected, and then they would be seen if they would fertilise after about 18 to 20 hours. So we always try and fertilise the maximum number of eggs, but with IVF, the eggs decide themselves with the sperm if they'll fertilise, and with ICSI, we pick out the eggs that have completed the correct stages of division. I hope that answers that question. The main reasons why an egg may not fertilise, that's probably one for Amy. But
I think we sorted on Facebook.
Okay.
I hope. It's really difficult because I can't get onto my phone to fix the problem that we might be having, but I hope we are live. So what was the question?
What are the main reasons why an egg might not fertilise?
Well, that's quite a difficult question to answer, and there's lots of possible reasons why an egg might not fertilise. Probably one of the most likely reasons is because it's immature. So what we look for is an egg that's at the right stage to accept a sperm, and we can't see that with IVF eggs. We can only see that with eggs that are going through ICSI. But when we look at the eggs the following day after we've attempted fertilisation, we can sometimes see that the eggs aren't mature and they would never have fertilised. They weren't at the right stage to accept a sperm. It's a very complicated process, fertilisation, and there's lots of things that need to happen for it to happen successfully, and lots of things that we don't know about yet. So all we can do is make sure that we've got enough sperm, and that we've kept the eggs safe and at the right temperature, to try and maximise the chances of fertilisation.
Yeah, good. Yeah. One of the questions I've got is, if someone's had a failed transfer and would like to go for a new cycle, what advice would we give to help improve their egg/embryo quality? So I think in terms of planning a new cycle, we need to look at what egg numbers we achieved and what embryo quality we achieved. And usually we like to try and get a maximum number of eggs that's safe to collect, and we'd like to get somewhere between 8 to 12 if we possibly can. But in terms of how can you improve the quality, there's lots of things that you can do at the start of preparing to go through that cycle. One of the things would be to look holistically at your lifestyle, any lifestyle changes that you could make. Sleep hygiene is important, and also one of our clinics within the group, the Zeta West clinic, they do particular preparing for pregnancy and look at the different supplements that might be necessary to help in preparing for a further IVF cycle. So I think it's worth definitely looking at the Zeta West website to understand if there's something that you feel that you may need to make changes about lifestyle or adopt different supplements that might suit yourself. But also vitamin D is very important and a very hot topic at the moment, and there's lots of information on there. So that's one of the first steps that you can make. Then one of the next things is to consider how well did you respond in your first treatment cycle. And we know that if you didn't respond very well and only got a low egg number, then there is the possibility of considering what's called a duo-stim cycle, where we perform 2 stimulation cycles back to back with a 5-day break in between. And that's because we know that there's been a number of papers now published that the way that the follicles develop can be in at least 2 to 3 waves of folliculogenesis, or creating the follicles. And we can collect the first wave, and then after 5 days we start to stimulate the second wave of follicles. And a large group from Italy have proven that in fact you can achieve across a short space of time a higher number of eggs from a woman who may respond poorly, and indeed you can actually improve the quality of the embryos you make, often from the second cohort of follicles that you develop. So that's something that we do at Chester, called a duo-stim, or a rapid sequence stimulation protocol. And as I say, we've been running it for just over 18 months now, and our data follows that they've seen in the larger clinics across Italy and in Spain. So we're quite happy to still continue with that. In terms of the next question. It was about supplements, so we've kind of covered that. Does high stimulation drugs cause embryo abnormalities, even if the embryos are high grades? So the stimulation drugs are to make your ovaries respond to produce an egg, and the maximum licensed dose is around 450 international units per day. And really, if you look at the European guidelines, anywhere around 300, 375, it really makes no difference when you go beyond that as to the number that you're going to achieve. But I think there is no direct link with the high dose to cause an abnormality within an embryo. It's all about making your ovaries respond to the medication. The next question was embryo development, and it's about the timing of embryo development and why some embryos develop quicker than others.
Yeah, so I think we've had loads of questions about embryo grading and as Vicky mentioned at the beginning, lots of specific questions about particular grades. So I think we'll just spend a bit of time on embryo grading, and I'll try and go into a bit more detail about that. But before I do, I think we've lost the Facebook live element, unfortunately, and apologies for the mouse and the clicking that meant that some of you couldn't hear. I was trying to fix it, but I was unsuccessful. So why do some embryos develop quicker than others? So I think the easiest answer to this question is that's just nature a lot of the time. So you think about adults, humans, children, we're all different shapes and sizes, and we all grow at different rates. Some are taller than others, and it's the same kind of principle with embryos. Obviously, the ones that are particularly slow or particularly fast might not be as good quality as the ones that are round about where we need them to be. So there are developmental milestones that the embryos need to reach on specific days of their development, and we grow the embryos in the lab for up to 6 days. And embryos, when they reach that stage around day 5 and day 6, that's what we call the blastocyst stage, where an embryo has got lots and lots of cells. So it goes from having around 6 to 8 cells on day 3 to having over 50 cells on, if not more, on day 5 and day 6. And embryos, when they get to this point, there's such a lot of activity and division and development that they develop into blastocysts at much different stages. But as long as the embryo has reached what we would class a good grade by day 6, then we would say that embryo has the potential to create a pregnancy, as long as we've graded it as good quality. So I hope that answers the different rates of embryo growth. And then embryo grading in a little bit more detail. So lots of you will know that we use a grading scheme in the lab to tell us the quality of the embryos. And this is usually a combination of numbers and letters. So you might have heard things like 4BB or 5CC, or even something like EXB11 or HB22, all of these different numbers and letter combinations, and sometimes they're a bit confusing. But what we like to say is that these grading schemes are mainly for the lab team, for us to be able to determine which embryo out of a group is the best one, based on those 3 parameters that I talked about earlier on. This is specifically blastocysts, day 5 or day 6 embryos. The different grading schemes that there are available, lots of different clinics use different ones. There are multiple ones out there. And what we try and do is help you try and work out what that grade means in terms of the embryo. So we say it would either be good, average, or poor quality. And usually we would only freeze embryos that we would class as good quality or have got the potential to create a pregnancy. So there's there's lots of questions about, can you explain embryo grading in more detail? And I think that I've covered that in terms of blastocysts. The 3 parameters that we look for, there's lots of different grading schemes out there. Those combinations of numbers and letters are mainly for the lab team, and we try and help you understand those by putting them into 3 categories: good, average, or poor quality.
I think that's where it comes in, where people are asking individual about, is a 2BB or a 2cc better than one or the other, or a 4BB, and that's where they're probably grouped together and would fall under the umbrella of good, and then you've got a group that might be then average, and I think that's, if you get too hung up on the individual grades, you might be trying to decide between 2 embryos that are actually essentially the same.
Yeah, exactly, Right.
And
working out or understanding that the grading is actually quite subjective. So although we have very rigorous protocols, and we all take part in quality schemes to make sure that we're all grading the same way, inevitably embryo grading is subjective, because we're all humans and we all see things a slightly different way. So what I might grade as a HB21, one of the other lab team might come across and grade it as an HB12. There won't be much variation, but there might be slight differences. So that's where, getting hung up on the difference between a 1-2 and a 2-2, or it can be...
it can be confusing,
exactly.
Whereas they're both good embryos.
Yes,
That's the thing.
yeah.
So one of the other questions we've got about embryo development is, we've had 5 rounds and our embryo stopped developing after day 3.
Yeah.
Can we improve this? So I think when we look at embryo development, and Amy, correct me if I'm wrong, as I'm not an embryologist, but speaking clinically, and the way I would explain it to patients within my clinical consultation, is up until day 3, the egg is in charge. And then after day 3, it's a combination of both the egg and the sperm that then continue that embryo's development. So now that the sperm has come into play in terms of the development, if that sperm is compromised in any way, then that could affect the embryo development beyond day 3. And how could we improve this, or decide whether the sperm is playing that fact or a major factor, is that it could be one of the things that are compromising the sperm is possibly oxidative stress on that sperm. And there is a test, the SOS test, that would look at that oxidative stress level on the sperm to see whether it is causing or has the risk of causing potential DNA fragmentation within that sperm, which may reduce the embryo development from day 3. I think that would be my simplest way of explaining it. And so possibly the SOS test would give more information to help you understand whether that's playing a big part in that reduced development from day 3 onwards.
Yeah. So going back to the embryo grading, we can talk a little bit about embryo selection. So I've talked about the subjectivity of the embryo grading, and that's one of the main tools that we use to select embryos. But we've also got time-lapse technology, which is incubators that have cameras inside them that take pictures of the embryos every 10 minutes, and that gives us basically a movie of the embryo development. So rather than without time-lapse, we would remove the dishes from the incubator and look at them under the microscope once or twice in their development. We have a whole movie of their entire development. So that information is really useful. And what we've got at CARE is something called CARE Maps, which is a method of embryo selection. And it's basically a tool that the embryologists can use to help select the best embryo in a cohort. So this tool was developed on lots and lots and lots of embryos that we know have created a baby, and we've used the images from those embryos to formulate a bit of information to tell us if certain embryos in a cohort also fit those patterns. And it gives the embryos a score of between 1 and 10, 10 being the best and 1 being the worst. And that's really quite useful when there's lots of embryos and they're all developing at different rates. That kind of technology helps us select embryos a little bit better in the lab and gives you, the patients, more information about the potential of the embryos that we're selecting.
I think what I get asked the most is when a patient knows that they've had a good, average or a poor quality embryo replaced. The first thing they will ask me is, but what's my chance with that embryo? And what the time-lapse assessment gives you is an individual score for that embryo that then it aligns with a percentage chance of live birth.
Yeah, exactly.
And I know that that's been run across about 6,000 embryos where we know the outcome. So it's robust data that I can then say, well, your embryo scored 10 and therefore your percentage of a live birth is this. Okay. Yeah. So I think that's where it helps. Now, there's a couple of questions specifically about time-lapse, saying that is it available for NHS patients? Is it something that you can add in to your pathway? Yes, you can, if that's the degree of information you want to know about your embryos. It's not part of a standard NHS pathway, and it would just add more information about putting your embryo that scores the best back first. And you would normally have to pay to add that into your pathway, and not all CCGs that fund treatment will allow you to add in things to your standard NHS pathway, so you'd have to check with your local clinics if that's a possibility.
Yeah.
Okay. It does say how are the embryos checked if you don't use time-lapse. I think, did you cover that earlier on about the left undisturbed? Yeah,
so as much as we can, if we don't utilise the time-lapse technology, then as much as we can we leave the embryos undisturbed and let them do what they're going to do. So we would only really check them for fertilisation on day 1, day 0 being your egg collection day, and then again just before utilisation, or so transfer, freezing, and that would be on day 5.
Sure. So I think the next section is asking, lots of questions are coming about PGTA.
Yeah.
The first question is it safe to perform PGTA on an embryo that's already been frozen?
Yeah.
And I think, well, you've done this quite a few times.
Yeah.
Haven't you?
So Care as a group do this regularly, and the information that we have is that testing embryos that are already frozen is safe, and it can be done, and the survival rates are comparable. Obviously, the embryo would need to be thawed. It would then be biopsied, refrozen, and then potentially thawed again. So that's things to consider when deciding to test already frozen embryos.
Sure. So the next question is, does PGS harm embryos, and why is it red under the HFEA? So first of all, for those of you who don't know, the HFEA have a red, amber, green traffic light rating system that provides information on their website to patients about the different treatment add-ons that you can add into your treatment pathway. And the basis of that traffic light system is based on the quality of evidence that shows, does something definitely improve your chance of pregnancy, or is it harmful to your chance of pregnancy? And the red rating means that at this moment in time there isn't enough evidence to say that it improves your overall chance of pregnancy. But what we can say is that it will improve your and may shorten your time to pregnancy by helping us select an embryo that we know has the genetic components able to make a viable ongoing pregnancy.
Yeah.
I think that's the easiest way of explaining the traffic light system.
Yeah.
But it doesn't harm embryos, but there is, as with anything, a small risk of damage during a biopsy procedure where cells are taken away from the embryo. But they're taken from the very outside of the embryo, is that not right? From the trophectoderm cells that would form not the inner cell mass that forms the baby, but that forms the supporting the placental structures. And 5 or 6 cells are taken from that area. And so we stay well away, the royal we, the lab, the embryologists stay well away from the inner cell mass. And that's my understanding. So I think harm is not the correct word. There's a small risk of damage.
It's worth saying that there is information on the HFEA website about PGTA if you wanted to get some more information about that traffic light system, but obviously people at your clinic are always there to answer questions that you have about specific things like PGTA if you wanted to.
So the next question was, why is a day 5 embryo better than a day 3 embryo, and can you choose a day 3 or a day 5 transfer? I think from the 2 parts to this. There's the part about the embryo, and then there's the part about the lining of the womb. And we know that in nature and normal conception, an embryo would reach the womb at about 120 hours post ovulation, and that this is approximately 5 days. So we know that that's when we would expect the window of receptivity within the lining of the womb to be at its best for implantation. And that's why the lab have tried to extend the culture of embryos to reach that day 5 blastocyst stage, so that you are putting an embryo back in that's as synchronous as it can possibly be with when it would be reaching the lining of the womb and the uterus within a normal conception. And there are lots of different reasons why you might have to have a day 3 transfer, and I think Amy, you're probably best to explain that. But
day 5 isn't necessarily always better than a day 3, but certainly we encourage day 5 transfers where we can, because it means that we get lots more information about the embryos that you have. So embryos on day 3 tend to look really similar. There's not a lot of difference between them. And as I said earlier, when they develop between day 3 and day 5, there's lots of development, lots of division, and we start to really see the ones that have got the capacity to create a pregnancy. So that's why we tend to we tend to advise day 5 transfers in lots of cases. It's all about more information, managing your expectations, being able to give you realistic potential chances of success. We're much more able to do that when we know what the embryo looks like on day 5. So yeah, I think that covers it.
So I know we've rapidly run out of time.
Yeah, we have, and I think maybe we a couple more, just because we had a few technical issues and we were a little bit late. Fine. So we'll do a few more.
Okay. So I think the next question was about why would a genetically normal embryo fail to implant if it had been tested with PGTA? And I think this is a really complex, because we're not just relying on knowing the genetic component of the embryo. There's so many complex interactions that have to happen to achieve implantation and then an ongoing successful pregnancy. So we've got what is going on within the host, within that lining of the womb at that time, on a molecular level, the interaction between the endometrium and the embryo are critical to implantation. So just having a genetically normal embryo does not necessarily automatically mean an ongoing pregnancy. And I think as a species, humans are not the best reproducers. Our natural ability to achieve a pregnancy in any one menstrual cycle and then achieve a live birth is at best 37%. We're not good reproducers. So I think that's where we have to accept that there will be limits, even when you know everything about the embryo, there will be limits to why it's not successful.
And implantation is really similar to fertilization. It's so complex, and there's still so much that we don't know, that we obviously do as much as we can to get the best embryo and to get the best environment, but there is only so much that we can control, and there's lots that we've still yet to find out about the human body and about implantation, that although we'd love for it to work 100% of the time, that's quite unachievable.
How much chance do frozen embryos have to get pregnant? So we know that, as Amy said, we only would freeze your top quality or good quality embryos, so that we know that they've got as good a chance as they can possibly have. And certainly across the group, our rates of frozen embryo pregnancy success is the same to a fresh embryo transfer.
Yeah. Okay, so we've gone over a little bit. We've had loads of questions coming through, and I'm really sorry that we haven't managed to answer them all. I think we've tried to answer questions quite broadly to try and cover all, and we really would love to answer every individual one. There are some really, really specific ones in there, but we would encourage you to ring your clinic, or if you've got an email contact, give them an email and ask some questions specifically, and hopefully we'll be doing another one of these really soon. Yeah. Okay. Thanks very much. Bye.